a webinar series that is sponsored by the Early Career Immunologist Committee, and it's generously supported by LACID and the USID Net, so we thank them for their support. And just a little bit of publicity, we'd like to invite everyone, especially trainees, to check out the website. You should see it on your screen. If you'd like to join the Clinical Immunology Society, it is completely free for trainees, and you can become a part of the Early Career Immunologist Committee, and we welcome you. So first we're going to start with a literature review that's presented by Dr. Joyce E, who's one of the faculty members at Columbia University.
Thank you. Let me see. I'm going to try to figure out how to, my presentation got very small. Okay. So I'm going to do a quick literature review on just some recent journal articles from the JOCI. So the first article I want to review is an autoimmune article exploring autoimmunity in a cohort of children with genetically confirmed Aicardi Goutieres syndrome. I don't know if anybody lost their visual on this. But anyway, so Aicardi Goutieres syndrome, AGS, is an inflammatory encephalopathy in the first year of life. These patients have elevated interferon alpha levels in the CSF, and they have basal ganglia and deep white matter calcifications, leukoencephalopathies, and cortical atrophy. The associated mutations are in the genes listed here, these several genes here, resulting in seven different types. And some of these patients also have lupus-like features. So the goal of this paper was to compare clinical features and the autoimmune antibody panels to determine whether there is any phenotypic correlation. So the authors recruited 17 patients with known AGS. 11 were males and 6 were females with a mean age of 127 months. Most of these patients were the type 2 AGS, so they had the mutation in the RNase H2B. So in terms of what their findings, about 9 of these patients, had a positive family history for autoimmunity, and include all of the different findings here, including thyroiditis, psoriasis, pemphigus, celiac, diabetes, lupus, arthritis, nephritis, and Chilblains. They had a whole host of various neurologic and developmental defects, in particular the spastic dystonic tetraparesis, which was in, I think, a majority of the patients. No subjects actually had a personal history of systemic autoimmunity, though, although a number of them did have organ autoimmune disease, for example, Chilblains, some with oral ulcers, and one with thyroiditis. A little over half had variable levels of positive autoantibodies, with anti-ENA being the most common. Some were positive for ANA, anti-nucleosome, antiphospholipid, as well as ANCUS, and most had a normal complement. However, none of these profiles were consistent with any particular autoimmune disease. So the authors concluded that these autoantibodies perhaps have no clear pathogenic role in this disease, but perhaps they're a product of this increased type 1 interferon production. And it goes to take-home message is that, just having positive antibodies to many things may not always be the culprit for the disease trigger. And perhaps in this disease, targeting the interferon pathway may be one way of treating these patients instead of doing mass immunosuppression. So the next paper I wanted to review was a phenotypic and functional comparison of class switch recombination deficiencies with a subgroup of common variable immune deficiencies. So as we all know, many defects in CVID remain as yet unidentified, and we've used B-cell phenotyping and recombination history to classify CVID subjects into subtypes. And having done that, we've seen that there's some overlap between CVID subjects and subjects who have defects in class switching. So the goal of this paper was to characterize and compare a subgroup of CVID subjects with subjects who have a well-defined class switch recombination defect. So the authors selected about 5 patients with CSR-like CVID subjects from a previously screened subject group of primary antibody deficiency patients. They were all B+ CVID category per the Freiberg or Paris and Euroclass classifications with normal T cell numbers, and no identified mutations were found in any of these genes listed here. And the authors examined B cell phenotyping, proliferation, plasmablast differentiation, and Ig production as functional studies, and they were compared to healthy controls, cord blood, as well as subjects with the CD40 ligand, AID, and UNG mutations. So just to kind of cut to the chase, in terms of the B cell phenotypes, the patients 1, 2, and 3 here had very similar B cell phenotypes, B cell subset phenotypes to the AID and UNG patients. So basically, majority having mostly naive and non-switch memory B cells, whereas the fourth and fifth patients seem to have phenotypes that are more similar to the CD40 ligand patients with primarily naive B cells. In terms of the functional studies, so table 4 is basically cells are directly stimulated with CPG, whereas table 5 are cells stimulated with CD40 and IL-21. So bottom line is, again, the patients 1, 2, and 3 had a functional profile that was very similar to the AID and UNG patients. And patient 4 had a similar profile that was similar to the CD40 ligand patients. However, interestingly, patient 5, in terms of the functional study, basically did not really proliferate or did not secrete much of any immunoglobulins whatsoever. So it's a very separate, different phenotype. So to summarize, so one of the major things that they found was that there were no major T cell defects in these subjects, in these 5 subjects. There was a variable B cell phenotypes and functional responses, with subjects 1, 2, 3 being very similar to the AID and UNG deficient subjects. Number 4 was very similar to CD40 ligand, whereas number 5, while it was similar to CD40 ligand in phenotype, had no almost proliferative or plasmablast differentiation in terms of the functional tests. So the authors suggest that this may be suggestive for multiple defects for the class switch like CVID subgroup. And so the take-home message that they're advocating for continuing to perform phenotyping and functional assays to help tease out these subgroups, and that will help us to further determine where the defects are in the B cell activation pathway. And the very last paper I wanted to review, very timely, is thoracic surgery in a chronic granulomatous disease, a 25-year single institution experience. So the chart review of CGD patients admitted to the NIH in an over 15-year period, 25-year period. There were 51 thoracic operations, accounting for about 13.6% of the CGD patients and 2.3% of the total admissions. The majority were male, and about 80% had X-linked CGD. However, they didn't find much of a statistical significance between the genotype and the risk for surgery. Many of the patients, 29 to 35 patients, tended to have the lower superoxide production, but that was not found to be statistically significant. The mean age of surgery was 15 years, and a majority of them had a prior history of pneumonia. Many of them had been on antifungals preoperatively, as well as several were treated with steroids, as well as interferon gamma. About 35 of these patients, these 35 patients had 1 or more operations, including wedge resections, segmentectomies, or chest wall resection, and about 80% of the cases, interestingly, were still noted to have fungus on culture or pathology. Aspergillus was the most common, and it was noted about 1/3 of these specimens, while they were negative on the culture, were found to be positive on pathology. Many of these subjects were found to have granulomas or granulomas changes on the pathology, and about a little over a quarter did have postoperative complications, including infections, respiratory failure, wound complications, and vascular injury. At the time of the analysis, about 1/3 of these patients had already expired. Over half were due to pulmonary infections, with a median age of 25.5 years. And they found that the survival probability was about 1.1% risk at 5 years and 61.6% at 10 years. So this article really highlights the potential risk of surgical intervention in CGD patients, particularly from the surgical perspective as well as from the CGD perspective. And having this data will really help us in advising our CGD patients for whom surgery may be considered. And that is it. So I'll turn it over to our moderators for the next presentation.
Okay. My name is Andy Snow. I am an assistant professor at Uniformed Services University in Bethesda, Maryland, and I will act as your moderator for our first case. It comes from Dr. Kiran Patel at Emory University and Children's Healthcare of Atlanta. And we're pleased to be joined by our senior mentor for the case, Dr. Rebecca Marsh. I hope she's here. She's the Associate Professor of Pediatrics and the Clinical Director of the PID program at Cincinnati Children's. Rebecca, are you here? Okay. Well, we'll hope she joins in soon, I guess. Perhaps we can get started. I'll turn it over to Dr. Patel, and I'll encourage everyone to please enter questions in the chat box as we go, and I'll try my best to get to those.
Okay. So I'm going to present a case called Lymphomas, Infections, and Bronchiectasis. Oh my. So this is a case of a 7-year-old male with a prior history of diffuse large B-cell lymphoma who presents with bronchiectasis. So at 5 years of age, he was noted to have multiple episodes of acute otitis media, as well as multiple pneumonias, as well as several sinus infections. They all had required oral antibiotics. Then at 6 years of age, about a year later, he was noted to have chronic cough for over a year. And after seeing a pulmonologist and having some diagnostic imaging, was found to have bronchiectasis. And during that time, that 1 year period, he was actually admitted twice for pneumonia, both episodes requiring IV antibiotics. Past medical history, with a history of prematurity at 26 weeks of age, as well as a history of asthma diagnosed at 2 years of age, and a history of constipation between the ages of 1 and 2. The history of the lymphoma was diagnosed when he was, again, about 4 years old, and for that he was treated with both rituximab as well as chemotherapy. He did have a complication during that time, which was a small bowel resection. The lymphoma was in the abdominal cavity, and he had an obstruction at that period and had surgery for it. He also had chemotherapy complications in terms of multiple admissions for recurrent infections during that time. So going further, he had no history of fungal infections or skin infections otherwise, and family history was negative for any history of immune deficiency or consanguinity. He actually has a healthy 2-year-old brother who is doing well. So when we saw him in consultation for the bronchiectasis, his weight was in the 7th percentile and height was in the 2nd percentile. He was normocephalic, he had no abnormal dentition or gingivitis on exam, and he was noted to have some mild angular cheilitis. His lungs were clear, belly was soft, unremarkable, and his extremities were notable for some mild clubbing. We did some initial immune workup for this patient with bronchiectasis and recurrent infections, and noted that his CBC had a normal neutrophil count, as well as a normal lymphocyte count and monocyte count. He had normal levels of platelets, as well as normal kidney and liver function. And we actually reviewed the historical lymph node biopsy from his original lymphoma, and it was characterized as malignant cells with irregular nuclear contours, multiple small nucleoli, as well as a small amount of pale cytoplasm. Those cells stained positive for CD20, CD10, and BCL6, and were negative for CD3,
Entry
CD34,
and exit chimes are on.
and TDT.
So, Dr. Patel, at this point, before I know you're going to move on to immune phenotyping, but based on the history in the labs, what are you thinking at this point in terms of a differential?
So for this patient, we were considering things like either a history of basically post-Rituxan or chemotherapy-associated immune deficiency, as there's been reported patients having hypogammaglobulinemia after Rituxan therapy,
right,
as well as primary immune deficiency as well.
Okay.
We can also ask the audience as to what at this point in terms of history, it's a 7-year-old with past history of lymphoma who seemed to have developed bronchiectasis and signed a pulmonary infection, and he has history of prematurity. So did get rituximab as a part of combination chemotherapy for diffuse large B-cell lymphoma. So I think we should just let audience also chime in before we go to the immunology profile to have what are the differential they're thinking, or is there any additional history they would like to know?
Don't be shy, guys.
Okay, let's move on to the immunology profile, and we will have more response come, and then we can go back and review the differential at that point. Okay, a couple of questions. Yeah, go ahead.
I was just going to say we've got a few questions coming in. In terms of the liver, the spleen on physical exam, was there anything notable there?
No, they were normal.
Okay. Any neurologic defects?
No, he was, sort of age appropriate, had met all of his sort of milestones, and didn't have any deficits on examination.
Okay. And Dr. Sharma is asking, did you get a platelet count, and what was that?
It was 463 and normal.
Okay. Okay.
So one of the curious questions
Go ahead.
Is like Eshim asked for neurological defects. Is there anything specific that she's having in mind, asking for neurological defects?
She's asking, is it ATM-like? Does this look like ataxia or?
Yeah, Kiran, was there any history of microcephaly, ataxia, anything in this patient concerning for like negligent breakage, AT-like syndromes?
No, he was, sort of small for height and weight, but from a head circumference standpoint, it was within normal limits.
And how about a thing for these patients?
Go ahead, Chan.
Sorry.
So one other thing for these patients is like they got chemotherapy, and if they've gone through chemotherapy without much complication, that is a very good challenge to see whether they have AT or AT-like syndrome. Most of these kids go through chemo and fall apart. So if it's not recognized underlying, there is an AT or AT-like syndrome. So the fact that this kid gone through chemo without much complication is reassuring in that aspect.
We have a few questions regarding infections. Were there any viral infections of note, or especially in the GI?
He did not have any viral infections that were, severe, requiring hospitalization or severe complications. No persistent sort of skin issues or sort of molluscum or other skin viral infections or warts.
And regarding the chemotherapeutic regimen, was there anything notable there? We've got a question regarding bisulfan. Was that used as well?
I do not recall the patient getting busulfan for his lymphoma treatment.
Okay. Well, let's go ahead and move on to the immunological workup.
Okay. So the immune workup initially showed, and the labs on the left-hand side are his current ones when we were evaluating him, showed a relatively normal T-cell count with about a 1-to-1 ratio of 4 to 8 CD T cells, and then a normal number of absolute B cells. But in the phenotyping of his B cells, it was noted that he had actually absent class switch memory B cells. He had normal NK cells, and he had normal DHR. When we reevaluated his records, they actually got immunoglobulin levels at the time of his presentation.
All attendees are muted and may unmute themselves by pressing *6. All attendees are muted. All attendees are muted and may unmute themselves by pressing *6.
The IgA level normal at the time of presentation. IgG was normal. The IgM was 113. They didn't do an IgE at that point. And then when we measured his levels again at the presentation of the bronchiectasis, he had absent IgA, very low IgG and an elevated IgM and an absent IgE. His vaccine titers were notable for absent pneumococcus. And then when we vaccinated him with Pneumovax, he actually had absent titers afterwards as well. His tetanus titers were also decreased and not protective.
Okay, well, so given the immune workup, so we've got normal T and B cell counts, but no class switch B cells. Clearly some issues with IgA, IgG production, and pretty poor responses to pneumococcal and tetanus vaccine. Are there any questions from the audience at this point or ideas about the differential before we move on?
Yeah, so this is Rebecca. Can you guys hear me now?
Oh, hi, Rebecca.
Entry and exit chimes are on.
I *6'd myself, and now I can talk. So I was just going to ask the audience. So in someone with absence of class switch memory B cells and a history of lymphoma, what other immune deficiency would you think about classically if they didn't have lymphoma, if you just had a male with recurrent infections and no class switch B cells?
Can I chime in here?
Absolutely.
Rebecca, okay. I might guess a CD40 ligand deficiency.
Yes, absolutely. That should absolutely be on everyone's list right now.
Outstanding. Is there anything that would differentiate at this point, though, between those two? In your opinion, Rebecca?
Between CD40 ligand and which?
Well, and I mean, is there anything that might give it away? I know we haven't moved on to the summary yet, but we can't differentiate further.
No, just any boy with recurrent infections and absence of class switch memory B cells. Now, I completely agree with Kiran. Your first differential in a kid who's had rituximab and who's had lymphoma, and we see this in the clinic all the time, is post-rituximab lack of B cell recovery. So that's number one. But now that you're getting into this, got to definitely remember hyper-IgM syndrome.
And there is also CVID being brought up by Joyce and Vignesh Sharma from India.
Absolutely.
And with the hyper-IgM phenotype, you're seeing the immunoglobulin now, like post-rituximab, showing IgM being elevated. Is there any other differential that's been considered? It's more for audience to pitch in. And again, Rebecca, if this is not CD40 ligand with decreased or absent class switch memory, and we have not looked at the T cell profile apart from looking at CD4 and CD8, we don't know the RARO and other proportions of it. I think it's more an audience question. What else would be considered with or without the presence of lymphoma?
We do have one idea from Dr. Hoyos. Could this be a mutation in PI3 kinase?
Absolutely.
Catalytic domain? Yep.
Yeah.
Good.
So I think there are two very good differentials being brought up, right? PI3 kinase delta and also SAP deficiency. So,
right. Okay.
Well, T cell profile that will give us a clue into either of these diagnoses. All of them might have a decreased or absent class switch memory, but will a T cell panel looking at CD45, RARO, TEMRA, and effector and central memory help us in the differential? The only other point I wanted to make is in PI3 kinase delta, we can have a very skewed memory phenotype, right? Like because of the mTOR overactivation. So I think they're doing a CD45 RARO might help to further differentiate within this differential of hypogam, absent class switch memory. What else are we dealing with?
Dr. Lawrence is asking if there's any increased risk of lymphoma with X-linked hyper-IgM.
There is. Not diffuse large B-cell lymphoma in particular, but yes.
Okay. Okay. Well, should we move on to the summary? So we have some good ideas on differential with PI3 kinase mutation, SAP deficiency, potentially CD40 ligand deficiency. Dr. Patel, do you want to continue?
Sure. So in summary, this is a 7-year-old male with bronchiectasis, recurrent sinopulmonary infections, and a history of lymphoma, status post-rituximab. His immune phenotyping showed absent IgA and IgE with low IgG and elevated IgM. He had absent vaccine responses to tetanus and pneumovax, and he had absent class switch memory B cells with normal T and natural killer cell counts.
Okay. Should we continue to the big reveal? Go ahead.
Sure. So we sent off for SAP expression. On the left-hand side, you can see a control versus our patient who has complete. And so the diagnosis was X-linked lymphoproliferative syndrome. And he was confirmed to have a known genetic mutation resulting in a cryptic splice site in exon 1, resulting in a loss of the initiation codon. And we had confirmed the lack of SAP expression in his T cells and natural killer cells with flow cytometry. So what I listed here are the sort of primary, sort of associated with lymphomas that you would want to have on your differential when thinking about patients with prior history of lymphoma. And so many of the cartilage hair hypoplasia, many of the DNA instability disorders, and then I think people had brought up the PI3 kinase deficiency as well as other combined immune deficiencies. And then definitely subtypes of CVID can present like this. ITK deficiency, autoimmune lymphoproliferative disorders, as well as several X-linked disorders with MAGT1 as well.
Okay. Well, we're basically ready to conclude. Are there any questions from the audience at this point regarding the final diagnosis? Or if Dr. Marsh, if you want to chime in at all, I know you're an expert in XLP1.
As are you. I'm more an XLP2 person. But I just want to make the point that, like, as a clinician, if I saw this kid in the clinic, and I see kids like this, I would have been really hung up on the fact that he'd had rituximab before. And I think I really would have focused on, this must just be lack of B-cell reconstitution post-rituximab. I might not have even done, as thorough of a workup as, you should. May have just started IVIG and had done with it. So I just think it's a really good reminder to always be thinking, outside the box in cases like this, and really do your diligence and, don't forget about XLP in kids with recurrent infections. And, a lot of times we think about kids with SAP deficiency as having burkitt's. So classically, if this kid had come in with burkitt's, especially like in his intestine, I think that would have triggered a lot of people to think about XLP1 and do the testing. But just remember, there's lots of other lymphomas that these kids can get.
Dr. Patel, we've got a question regarding management of the patient. Would you take him to bone marrow transplant?
We are going to take him to bone marrow transplant.
Yeah, and I would agree with that.
Okay. And Dr. Holland's asking a question about, back to the issue of post-rituximab failure. How hard should we be looking for defects in that situation?
Well, this case suggests you should be doing, a really good workup. So, with the advent of panels and whole exome, that makes things a little easier.
Sure.
Instead of trying to piecemeal. I mean, if you made a list of all the genes, you would do in this kind of case, it'd be really complete. It's a lot cheaper just to move on to either a couple of panels, like, is it ARIP that has the 30 gene primary antibody deficiency? I'm pretty sure.
This is the
so doing that, and that's definitely got CD40 ligand in it. So doing like that sort of panel, it's got PI3 kinase delta. So that panel, maybe plus either SAP or doing the sequencing for SH2D1A It'd probably get you pretty far. It wouldn't get you very far for CID, but your phenotyping and your functional studies are really going to tell you if you need to look for CID genes or not.
Mm-hmm. And we have a question.
Go
ahead. Go ahead, Shan. Are you there?
Yeah, I was just curious, since this is one presentation of XLP, but we have XLP present in multiple different cases. So if Rebecca can comment about HLH, dysglobinemias, aplastic anemias, that spectrum, we have not discussed that, so that audience might also recognize them. They don't present always with lymphomas and hypogam, but there are other manifestations of the same defect.
Yeah, so HLH is probably the most common, probably 60, 70, 80% of kids. It tends to almost always be in association with EBV and XLP1, as opposed to other HLH disorders. We really see a broad gamut of triggers, but we have seen at least one kid with HHV6 associated HLH who had XLP1, but that's the most common, and it's the most deadly. So I think, 20 years ago, mortality in XLP1 kids with HLH from EBV was 90%. It's definitely better now, but it's hard to recognize them sometimes in time just because they come in so sick, and depending, where they are and what people are thinking of, it's hard to pick up. But Shan's exactly right. About a third of them will get either dysgammaglobulinemia or hypogammaglobulinemia. About a third of them, I think, will get lymphoma. And most common is Burkitt's. So whenever you see a kid with Burkitt's, especially recurrent Burkitt's, we had a kid, I think Shan probably knows who this is, but 3 rounds of lymphoma. So obviously that's very unusual, should be checked for XLP1. And then the aplastic anemias and things are rare. So 1 to 5% can get aplastic anemia. CNS vasculitis is a big problem. Kids have seen quite a few kids with CNS vasculitis. She's very sensitive to that.
Okay.
I think one other thing in the list of lymphomas is do we have a differential between if you have recurrent Hodgkin's versus non-Hodgkin's? At least in the differential that is put up there, ITK deficiency I know is recurrent Hodgkin's, and maybe ALPS can have both Hodgkin's and non-Hodgkin's. So is there anything that you think of specifically if a kid comes with this more recurrent versus Hodgkin's versus non-Hodgkin's with underlying infection?
Hodgkin's, honestly, I just like you said, I think about ITK deficiency.
Rebecca, is it known what you mentioned the prevalence of Burkitt's in XLP1? Is it known, mechanistically what the connection is there with SAP deficiency? Why Burkitt's is presenting more?
I don't think so. Okay. You might even know better than me, or chemicals may know better, but I don't think so.
No, I'm not aware. Yeah, that's okay. Dr. Patel, did you get an EBV viral load in this patient, or check at all about EBV status?
Yeah, so the actual original lymphoma was negative, and the patient continues to be negative right now. So we actually are going to give him rituximab to get rid of all of his B cells, so he's at low risk for HLH from EBV while we're pending the transplant for him.
Okay. Okay. Are there any other questions from the audience or any other comments?
I think there's one other one that I guess how hard should people be treated with cancer for immune deficiency?
What was the question? I just couldn't hear it. It broke up.
There was a question about patients presenting with lymphomas for the first time. Should there be an initial immune workup for these children to wait for immune deficiency at the time of presentation of just cancer?
Yeah, So I think depending who you ask, you'll get a different answer. If you polled a bunch of immunologists, I would say several will say yes. Some will say no, though. And if you ask oncologists, they most likely will say no. They really do tend to limit this to patients with either recurrent infections or problems with like systemic viral infection as they're going through their treatment. At least that's the practice at our institution. We really don't get consulted until people are coming in with pneumococcal sepsis and things like this. And, most of their patients do well. They get treated for their ALL and they go on in 90% survival. And we never see most of those patients. So probably not, until the day when we're all getting whole exome sequencing when we're first born. Probably routine run-of-the-mill kids can, not be evaluated, but the ones that seem suspicious, or like the kids that have microcephaly or they look like ligase 4 ATM patients, et cetera, probably not your routine run-of-the-mill kids. I don't know what maybe Shan or Karen think.
All attendees are muted. Entry and exit chimes are on.
Hello?
Hello?
Is everyone there?
Yes.
Yeah.
Hello?
Yeah, I think we should wrap. This is great. Thank you so much, Rebecca. And again, Andy, thank you so much for moderating this case. And Kiran, thanks for a very interesting discussion on this case. I think we will, one last question. I do see Dr. Holland's comment on most molecular probes do cover most of these genes, especially whole exomes do cover most of these genes. Yeah, I do have a couple of families to come with the whole exome report at like a year of age with some dysmorphism. They did a whole exome and caught some random immune deficiency. Okay, moving on to next case. We have another interesting case to be presented by Vignesh Pandiarajan from Advanced Pediatric Center of Postgraduate Institute of Medical Education Research, India. I think he might have some audio issues. On his behalf, I think Amit Rawat, who is an additional professor in Pediatric Rheumatology and Immunology, will be presenting his case. Amit, can you hear us?
Yeah, I can hear you.
Okay. And as a senior moderator and expert on this, we are having Professor Steve Holland, who is the Director of Intramural Research at NIH. So no better person to talk about CGD and be an expert on that. So we are excited to have him moderate and be an expert for this case. So Amit.
Wait, is this the case?
Hello?
Hello, yeah. Can you see the slides?
No, I can't see the slides. I'm just seeing the microphone settings.
Okay. Let us know, like we will give you maybe 10-20 seconds to see if we can. Otherwise, then one of us will read out the slides. And if you're available even through audio, that will be helpful.
No, I'm not able to see the slides. I'm just seeing the microphone settings. Use microphone, use telephone. So I click the microphone setting. Click here to. No, I'm not able to see the slides now.
Okay. Maybe I will start presenting the slides. If you're able to comment on it and be available, like I don't know the case in detail, so you and Pandiarajan will know the case in detail. So, So the case for today's discussion, I think, has presented to this primary institution at 4 years of age, but came in with a past history that was significant. At 2 years of age, had low-grade fever, cough, weight loss, and rapid breathing for 3 weeks. And this is a very common presentation in India, so they did a tuberculin test that was negative. And the chest X-ray at that point showed bilateral diffuse chest infiltrates. Most patients, by default, if they have this radiological finding and have this clinical history, do tend to be empirically treated with antitubercular therapy. So he did get 4-drug combination antitubercular therapy for 6 months. However, his symptoms recurred 3 months after stopping antitubercular therapy. So he got another second course of 6 months of antitubercular therapy. So basically here he has completed 2 courses by then. And at 3.5 years, he developed a tender, progressively increasing vertebral spinal protuberance in the lower cervical spine. And the CT of the chest showed fibrosis, calcification of the right upper lobe, and bony vertebral erosions at T1 to T4 level. And treated again for suspected tuberculosis relapse. And at 4 years, he came to the referral institution, I think the parent institution, with his other significant history has been there is no history of contact with tuberculosis. He was first born to a non-consanguineous parents, and no family history of recurrent infections or sleep death. There is an insert that shows the chest X-ray findings. As you see, there is bilateral infiltrates. And his physical exam is remarkable for his significantly underweight and wasted. Pallor was noted, no clubbing or lymphadenopathy, localized kyphosis of the lower cervical spine with mild scoliosis towards the right side. Right-sided paravertebral soft tissue swelling was noted from T2 to T6. And otherwise, his cardiovascular, respiratory, I'm not too sure whether his respiratory was totally normal. Abdomen, I think it's normal, no liver or spleen, and cranial nerve examination was within normal limits. Is there anything you want to add, Amit, on this history?
No, I think you've covered much of it. But I think on the physical examination, they did find something on the auscultation because the lung involvement had not completely resolved despite having the ATT for 6 months and then again.
We cannot hear you well. Okay, I'm moving on to the next slide. So,
Hello.
Entry and exit chimes are off.
Hello.
Is everyone still on?
I'm still here.
Okay, I think we lost Emmett, his audio. I'm not sure what the issue was there.
Okay, well, we can keep going with the
Sean,
case
are you
if you.
still on the line?
Okay, well, why don't we just keep going? It's clear that some people still on. Jen, you want to keep
Sure.
doing the case?
Shan, are you there?
Okay, so let's pick up on the slides here. We've got the labs and the scans and the noteworthy thing. So now we've got a 4-year-old who's come in with recurrent tuberculosis. and has an excrescence on his back and abnormal chest X-ray, we've got a white count that's clearly elevated at 23,000, as well as thrombocytosis at 580. And then I think the really impressive point here is that he's got a very significant pan-hypergammaglobulinemia with elevations in G, A, M, and E. You might get distracted by the E being high, but the fact that the G and A and M are also elevated really with this recurrent infection history certainly makes you think about other things that might be going on. What do people think about the ANA being positive? Do we think this is a funny manifestation of spinal?
Hello, can you hear me?
Yep. I can hear you, Shan. Yep.
Okay. Sorry, I don't know what happened. So thank you so much, Dr. Holland, for pitching in. So so ANA is positive, and there is pan-hypergammaglobulinemia, and IgE levels are also elevated. So Dr. Holland and the audience, what are the differentials we would think at this point?
So we've got a couple of questions, a couple of possibilities here. One question is, how high is the ANA? I don't know. It says 2 to 3 plus positive, which I suspect means relatively high. But the suggestion that it might be due to the hypergammaglobulinemia, I think, is correct. That in the setting of, as you already know, this is chronic granulomatous disease, hypergammaglobulinemia is common. And in the setting of uncontrolled infection, we often see positive autoantibodies, especially to the lupus anticoagulant. And interestingly enough, these fade over time as you treat the infection. The ANA is intermittently positive, and the autoimmune diseases are more common in chronic granulomatous disease than in other settings. Although we don't check the ANA often enough for me to be confident that I know that it's typically high or low. But I think autoantibodies in general get higher in these patients.
Okay.
How often do you see IgE is often elevated in chronic granulomatous disease, but not usually this high. It's usually the eosinophils are typically high in the 5 to 10% range, and the IgE can be elevated, but rarely to this level.
Should we move on to the next slide? So the MRI shows a very definite vertebral lesions, right? Like, how common is osteoarticular manifestations in this disease?
How common is what?
Osteoarticular, I think there is significant spinal process, vertebral involvement. And so within that context, how common is having a vertebral lesion presenting as Pott spine in CGD?
I think that the reading was that there was on the X-ray, maybe when it was 4, that he had lung involvement involving the spine. And the most common thing we see is that spine involvement is secondary to lung involvement, and that you have a pulmonary focus that goes out from the lung into the spine. In this country, at least, that's typically due to Aspergillus species that are not Aspergillus fumigatus. Aspergillus fumigatus tends to be comfortable staying within a tissue plane, but when it starts to go through a tissue plane, it makes you wonder about a non-fumigatus Aspergillus species. The you can have primary osteomyelitis of the spine in CGD. It just isn't usually with Aspergillus going from a hematogenous route. So if I saw spinal involvement, I would be looking very hard for lung involvement nearby.
And even before we conclude this with CGD, I think there was another thought process. Can it be MSMD or any other TB predisposing lesion with an immune deficiency? When do you really think of MSMD, and what would be the clinical pointers towards it?
Well, I think it was mycobacterial. Think more about a genetic predisposition to mycobacterial infection. I think the most important thing you have here is that you have a child who's been recurrently sick, who had no serologic or immunologic evidence of tuberculosis and no family history of tuberculosis, who's now got at least 3 and maybe 4 episodes of discrete infection, and now you've got a big infected mass with bone involvement. I think the right thing to do is what people did, and that's to go and get some tissue.
And if this is mycobacterial disease, like there is one question being raised, can this be STAT1 deficiency?
I mean, it could be STAT1, it could be interferon gamma receptor, it could be IL-12 receptor. I don't think that there's a way to know that the clinical picture.
Okay. And just going over the slide, this kid, by at least pathology, shows epithelioid cell granuloma, and fungal serologist is showing Aspergillus flavus and fumigator. And the paravertebral soft tissue yielded only Acinetobacter. Do you typically attribute it to CGD, Acinetobacter? It's not one of the common CGD infections, right?
Well, Acinetobacter is a very unusual infection, and I guess I would go back to the laboratory at this point and ask exactly how did they make the identification of Acinetobacter. Once you get into these funny gram-negative rod infections, laboratories can be easily misled depending on how they're doing their identification. So whether it's by molecular or by MALDI or by chemical analysis. So, I mean, I think, whatever grows is what you've got, but I would be a little concerned that Acinetobacter might not be the right answer, and I would probably be going to the micro lab to ask them how confident they are that it's Acinetobacter, and I would insist that they speciate it in order to figure out exactly what the organism is. But Acinetobacter might be something that could do this. It would just be a very funny cause. You've got 3 items on the table now. You've got 2 different Aspergillus by serology and 1 bacteria by culture, none of which quite explain exactly what you're seeing. So I'm not positive you know the right answer, but it would be worth being confident about it.
Okay. And I'm going to move on to the next slide. I just wanted to make sure that the audience have any other questions. It looks like a 4-year-old kid with what was presumed to be tuberculosis has been treated as tuberculosis for at least 3 different occasions, not responding, but has progressed to both vertebral and also chest lesions. The only things that have come back positive are Aspergillus serology and paravertebral abscess growing Acinetobacter. As Dr. Holland has pointed out, it may not be Acinetobacter. There could be other gram-negative rods. So, and in terms of immune workup, there is ANA that is 2+ positive, and there is hypergam. Is there any other differential that the audience want to entertain at this point? So one other question for Dr. Holland would be, how reliable are aspergillus with allergy? I think Amit Rawat from Chandigarh is asking this question.
I'm really not sure, and I think just because a serology is positive would not make me confident I knew that that's what was in the lesion at hand. This child has had several infections several years, so I don't know that I would put a lot of stock in that. And certainly something that goes from the lung into the spine almost always will be fungal in CGD. So I'm a little puzzled about how to connect his lung to his spine to his paravertebral space.
Okay, so I'm moving on to the next slide. So interesting enough, they did do a DHR, and based on what I presume was a granulomatous pathology on the biopsy. And again, one thing I'm not too sure is, how do you differentiate a tuberculous granuloma from a CGD granuloma if AFP is negative, or any molecular testing for AFP is negative? So is there any specific characteristics in the granuloma that we look for to differentiate, okay, this is TB granuloma versus the real CGD granuloma?
I think the way that you're sure it's a TB granuloma is when you find TB.
Okay.
I don't.
So,
I mean, they made a fantastic decision to search for chronic granulomatous disease based on the fact that this was a child who had recurrent infections and did not have evidence that it was tuberculosis, and he grew an organism that would not be expected in TB. And I think this was really a brilliant decision to go and look for this and to run his mother alongside to verify that it was an X-linked form of the disease. I think this is a beautiful example of that.
Within the CGD diagnostics, the DHR, what other, I just wanted to bring up discussion, confounders for falsely low DHR. So SLINK is very classical, but in autosomal recessive, we can have mild shifts in mean channel intensity and still might have an autosomal recessive CGD, right? So, so what are the other conditions that can give a false low DHR? I think this is more for audience, and based on what response we get, I'll ask Dr. Holland to interject and give his opinion.
Okay.
So there is myeloperoxidase deficiency that was brought up. And how common and when do you classically think of myeloperoxidase deficiency when we do a DHR and something comes back really low?
Oh, and this is a beautiful. I mean, people are absolutely right. Myeloperoxidase deficiency is the right thing to be thinking about as the other defect that could look like this. The giveaway here that that's not the case is that the mother has a lionized example. Mom has two peaks, which you do not get in myeloperoxidase deficiency, since myeloperoxidase gene is not on the X chromosome. So in this case, you've proven that this must be chronic granulomatous disease because mom is a carrier and the child is affected. Despite the fact that the myeloperoxidase defect gives an abnormal DHR, I think it's relatively uncommon that it gets confused. And the reason for that is that very few people with myeloperoxidase deficiency actually get sick enough to be tested for chronic granulomatous disease. So I think the overlap happens, and Key Milligan from our group has published a nice example of that, but it happens very rarely because those patients don't usually come in to be tested for DHR.
Okay, thank you. One other thing that Amit is bringing up is most patients with MPO, myeloperoxidase deficiency, clinically present with diabetes. And that's a good point to know. And MPO, sometimes we do flow. It's a common protein, at least in leukemia lymphoma world, they keep looking for MPO positive or not. So it's another easy way of knowing whether there is MPO expression on your neutrophils or not. So if apart from the DHR, I think we can also go and look for MPO staining by flow. That's pretty easy and straightforward. So the genetics had suspected the mutation in CYBB predicted to be pathogenic, and as shown by the flow, mom is a carrier for this mutation. So, Dr. Holland, is there anything specific characteristic of this mutation in terms of clinical presentation?
The important point of the mutation is that it's after amino acid 310. So that means it's in the intracellular domain of the GP91 protein, and all mutations after 310, whether they're missense or nonsense, tend to be severe and to have zero superoxide production, as is the case for this boy. So I think, this is a recognized mutation, and you would look at it and say, boy, a change seen to an arginine is pretty significant, and it's in a domain that does not tolerate variation. So this is likely to be significant for him, and it obviously was.
And in terms of management for these patients, when do you typically consider, okay, interferon gamma might be an option? What would be a patient you would consider interferon gamma versus, okay, this patient I need to refer to transplant versus we can just do medical prophylaxis and interferon gamma in combination? What would be the metrics that you'll be looking in a patient to decide on either of these approaches?
That's a very, it's a moving target. And in this country, and there's a lot of variation in practice around the world. In this country, we would say that every child with CGD should be on trimethoprim sulfamethoxazole and an antifungal, initially at least itraconazole, and interferon gamma. Now, we'd say that, but many children are not on interferon gamma. It's expensive, it's difficult, and people, I think, are not familiar with it. In terms of who should be transplanted, that's a different story and is changing around the world. As transplant gets better, I think that it is something that is being considered for all children, especially those who have the severe mutations like this child, who will for sure do better with transplantation. That's a question of what's available.
Okay.
So I think
and one other quick, going back to this case, like he had the ANA that was positive. How commonly do you screen for, how common is autoimmune manifestation in this patient, and how commonly do you screen for both on mom as a carrier, screening parents for, like mom for autoimmune or infectious complications, and also the patient for autoimmune or autoimmune complications?
So mom is moderately likely to have an autoimmune issue, either discoid lupus erythematosus or some other autoimmune phenomenon. The child has a modest risk of autoimmune phenomena ranging from idiopathic thrombocytopenic purpura to discoid lupus. But usually for the boys who are affected, their course is dominated by their infection susceptibility. But the autoimmunity can be a problem. I'm not sure how much I would pay attention to the ANA at this point. I would ignore it until he had been treated for his infection, as Amit obviously did very successfully. And once the hypergammaglobulinemia resolves, then I would go back and see whether his ANA is a persistent feature. I think you're dealing in CGD when they're actively infected. You've got a polyclonal stimulation to B cells. Unlike the last case where we had lots of B cell deficiency, here their B cells are very active. And maybe that contributes to the autoimmunity, maybe it's something else. But I wouldn't pay too much attention to it after you had treated his infection.
Okay, one other last question, like there is duration of antifungal treatment for a known, like for this patient. How long would be the antifungal treatment if this is a fungal abscess or fungal infection. And the second thing is the role of steroids in this patient if there is significant hyperinflammation or the abscesses for the management of abscess in this patient.
Well, I think for the duration of antifungals, the duration for us is until the infection is resolved. So that means that the C-reactive protein has to get better, the imaging has to get better, the child has to get better. And then we usually go a little bit longer than that to make sure we got it all. In terms of steroids, steroids definitely help with the hyperinflammatory reactions in chronic granulomatous disease. But you have to be careful not to use them until you're absolutely certain you know what the infection is and that you have it under antimicrobial control. So we like to use steroids, but we need to be sure we know that we've got microbiologic control before we begin to use them. That being said, a couple of days of steroids probably aren't going to hurt anybody as long as you've got the right drugs on board.
Okay, I think we are running out of time, and we are like almost 8 minutes over time. Thank you so much, Dr. Holland, for the discussion. This has been a great discussion on this case. And again, I apologize we are not able to get the presenters in, but I think we are still able to go through the case and have a very good discussion on this patient. Again, on behalf of CIS, I would like to thank everyone who have come and logged in as an audience and have actually participated in this discussion. And special thanks for both the presenters, and Joyce, Kiran, and Vignesh and Amit, who really made this interesting case and sent us a PowerPoint through. And thank you again, Rebecca and Dr. Holland. And my co-moderators, both Monica and Andy, for helping to get put to this program. And we look forward to the next webinar in October 27, right? Yeah, October 27. So if you have any specific comments or feedback, please email us back to CIS. And we are always looking for more cases. Interesting ones from throughout the world. So if anyone has any interesting case and are very interested in presenting, please do contact us. We are always looking for some interesting cases to discuss. Thank you so much. Have a good night.